it's one of the reasons as you age at a more rapid pace, is because we're accumulating these senescent cells. And so they truly are like zombies, right? They're these damaged cells that are spewing out these proteins that are damaging the cells around them. So what they found in some of these studies out of China is when they took cells from either sick or damaged mice and they put them into healthy, like cartilage tissue, it actually initially created a positive response, but over a brief period of time, it actually started having a negative response.
Welcome back to another episode of the Peak Performance Life podcast. I am very excited to have an expert in a very important new up-and-coming field of peptides. We will be speaking today with Elizabeth Yurth, MD. She's been treating patients 25 plus years in her orthopedic practice, specializing in sports, spine, and regenerative medicine, but frustrated that her patients weren't getting the answers they needed to fully recover, gain back their health, and be active. Dr. Yurth co-founded Boulder Longevity Institute, BLI, in 2006 to focus on regenerative, anti-aging, and longevity medicine. The Boulder Longevity Institute specializes in advanced research-based longevity medicine, including treatments such as bioidentical hormone replacement therapy, regenerative peptide therapy, and much, much more. She has a very long list of accolades from all of the top anti-aging institutes, as well as universities and things like that. So, but let's jump right into it. Dr. Yurth, thank you so much for joining us today.
Thank you. I really appreciate being here.
Yeah. I'm really excited to get into this. So maybe I guess let's start with a little bit of a background of how you kind of got interested in kind of the longevity and peptides and things that you're working on today.
I think I came around this sort of in a very long road that if you look at most doctors who've gotten into functional medicine, a lot of them came from ER, a lot of them came from internal medicine. Orthopedics not. Orthopedics still is a pretty much, I think people think about overall health and then they think about their joint health as two different things, and they're really not. So I was working in orthopedic medicine, sports medicine for almost 30 years. And, working with professional athletes, high-level sports teams, and doing your typical, see an injury, stick some steroids into it, stick some more steroids into it, send them to a little PT, put some more steroids into it, finally do a little surgery on it, and then it's not any better, and then ultimately down the road replacing the joint. And about 18 years ago now, I started to get sort of frustrated with that. I felt like, wow, all we do is kind of patch people a little bit. They're never really, and if you've ever had an injury, you never quite feel the same, right? You're always like, well, okay, I guess I'm better, but I'm not great. And so I really got kind of frustrated with what I was doing for people. And I started looking into what can I do better? And I started looking into, well, maybe we could utilize nutrition better. Maybe we could use hormones better. And so this is kind of the early phase of the whole longevity realm. And A4M, which is one of the big anti-aging institutes, was 500 people. Now it's 5,000 people. But back then, so I started looking at where could I get this education? And I started learning more about, well, how does nutrition status affect our health, our joint health? How do hormones affect our joint health? Because that's a huge piece. For instance, if you don't have testosterone, you can't heal an injury. If you don't have progesterone, you're going to have more joint inflammation. You're going to have more back pain. So I started actually utilizing these things in my orthopedic practice. But that turned those 15-minute, insurance-based appointments into undoable. You can't teach somebody about health in 15 minutes and explain to them joints. You can very easily stick steroid into a joint in 15 minutes and send them on their way. So 17 years ago, we founded Boulder Longevity Institute. And what I did for a long time was wear two hats. I'd wear my orthopedic hat all day, and then I'd come over to my other clinic in the evening and actually feel like I was helping people. And so a lot of those patients crossed over. They would see me, there, and then start seeing me at my other clinic. And then really only about 4 years ago now did we merge those two together. And, it really kind of stemmed from, sometimes you need a big push to get yourself out of a situation. And I was in, a good practice and, making good money and owned a surgery center and an MRI scan center. So it was very hard to walk away from that. But as I got more and more frustrated with the fact that I actually probably was doing a disservice to people and not helping them, finally, the final shove was one of my partners came up to me and he said, you spend too much time with your patients and we don't do medicine here. We do orthopedics. And I thought, okay, obviously this is not going to work. So we merged the two together. We still do a lot of regenerative orthopedics here at our clinic now. So we do a lot with regenerative therapies for orthopedics, but a lot of how do we treat people with orthopedic injuries systemically to make them healthy? And how do we teach a whole new paradigm to people understanding that their worn out hip and their worn out knee is not because they ran too many races or they hiked too much or they played football, because that actually is not the cause of a joint wearing out. It is an inflammatory disease. And just like your heart shouldn't wear out because it beats too much, or your brain shouldn't wear out because you thought too much, your joints shouldn't wear out because you use them too much. There's some other process going on. So that's what we've spent a lot of years dedicating, is trying to educate people in this realm. And then that really got me from using hormones and nutrients into actually utilizing more what we call repurposed drugs and peptides, where we could actually start treating different pathways to try and help people. So it's kind of a long road to where I am now, 30 years later from my start of practice to where I am now, where we really treat very holistically and we treat whole body, even if somebody comes into us with knee pain. So if that's their primary complaint, obviously we're going to address their knee, but we're going to teach them how they need to look at all the other stuff going on if they're really going to make their knee healthy.
I absolutely love that story. And I absolutely love what you're doing there, combining the two. I think it's so important. Like you just mentioned, longtime listeners know I'm huge. Everything is, for me, health is all about lowering inflammation in the body, right? Is like we talk about that all the time, inflammation is the cause of almost every disease. It's like if someone is eating like crap, drinking alcohol, and they have knee pain, and then they go get a knee surgery, 6 months later, it just might pop up in their shoulder or the other knee or whatever, somewhere else, right?
Exactly. Yeah. And honestly, even if you temporarily, knee arthroscopy, which is a bread and butter surgery here, you go in with knee pain, we stick a few steroids and it's not better. We go, okay, let's go scope it and clean it up. That surgery has actually been banned in every other country because we well know now that it makes the joint worse, temporarily better. And then you rapidly progress the arthritis for exactly the reasons you stated. We've not treated the inflammatory component. And in fact, by doing the surgery, we've made the inflammatory component worse. So now that joint progresses, but so do other joints, right? Yeah. And I think what people don't realize is that if you have arthritic joints, you have a 10-fold risk of cardiovascular disease. And it's not because even if you stay active, so it has nothing to do with your activity level. It has to do with the fact that the same inflammatory process that actually causes some degradation of the joint actually affects the heart. So there's these cytokines called interleukin-1 beta is one of them. Interleukin-1 beta is elevated in bad heart conditions and in bad joint conditions. So most people who have bad joints have high levels of interleukin-1 beta. So they are at a high risk for cardiovascular disease. And people don't realize that, right? They think, oh, it's my knee. That doesn't have anything to do with my health. And, and so it seems to be the last bastion where I think people are starting to realize, as you did, that, if I have pain, it's probably inflammatory. If I have metabolic disease, I need to get my inflammatory control with diet and everything, exercise and those kinds of things. But joints have sort of been left out hanging, where that's a completely different thing. Nobody goes to their functional medicine doctor with knee pain, right? That they go to their orthopedist, and their orthopedists are doing the same archaic things that they were doing. I mean, I will tell you, being in practice for 30 years, my practice did not change one iota from where it started. We were doing the same surgeries. We were doing the same processes. Nothing changed. There's no other field. I mean, if our phones were the same as 30 years ago, we'd be like, wow, what's going on? But in, this type of medicine, we've just accepted it.
Yeah. Wow. That's unbelievable. Yeah. Hopefully we'll make some progress, but wow, that's crazy. Yeah. So let's talk about now, what are some new ways again, then so someone comes in and they have knee pain, shoulder pain, whatever it may be. What are you looking at now? What are questions you're asking them now? What are you trying to work on?
I think much like every aspect of health, and you've learned, I know from your health journeys and listening to your podcast, which you've had some amazing guests, that the first thing you're always going to have to look at is overall health, right? Is this person metabolically sound? Do they have super high insulin levels? Insulin is inflammatory, right? So if you came in with knee pain and I said, what does your diet look like? What do your insulin levels look like? You'd be like, well, that's just crazy. But it actually has a huge effect, right? You can't have high insulin levels and not have inflammatory disease in your body. So first and foremost, you're always going to look at diet. You're always going to look at metabolic status and see if that's playing a role. And then the other simple thing is if you look, where does arthritis start to affect us? Not so much when we're young, right? It starts to affect us as we start to get more into our, over 40 age. And that's because one of the things that happens is that we become more hormonally unsound, right? In women, our hormones start dropping very young, and men a little bit later, but still by 40s. And now we're even seeing guys in their 20s who have low testosterone. And so if you have low hormone levels, the joint is not going to do well. People don't realize, for instance, progesterone, which is important in both men and women. But progesterone actually there's receptors, not only, on your sex organs, but your brain and your joints. So one of the big causes, for instance, of just achy back, achy stiff joints is low progesterone levels. So we always kind of advocate to our patients that we have to look at this whole system. So we start there, looking at the very basic stuff. But let's say all that is good. Well, then it actually gets a little deeper, right? Because you look at somebody like me, I have end-stage arthritis in my knees. Anybody would look at my knee x-rays and say you need them replaced. I've had 4 ACL reconstructions, failed those. They just kept re-tearing them. But I have zero pain in my knees. They're bone on bone on the x-rays. Actually, I haven't x-rayed them in a long time. Maybe they're better now. But I don't have any pain. And why is it? It's because I've got my inflammation under control. But I was a pretty healthy person despite that. But if I look, my dad had horrible knee arthritis. So if I look at my just inflammatory cytokines, I genetically make high levels of tumor necrosis factor alpha, interleukin 1 beta. So I'm making higher levels of these cytokines that are destructive to my joints. So when you get an injury to your joint, right, you tear your meniscus, you strain your ligament. The first thing that happens, like in any disease process, an acute viral illness or an acute injury, your body goes into an inflammatory state. That's a good thing. For instance, when you get a virus, you should get a fever. You shouldn't quell the fever. The fever is a good thing, right? The same thing's true when your joint gets injured. The first thing you should not do is put ice on it. That's quelling that inflammatory state. We actually want that. We want that inflammatory state. There's very good data now to support that if you start icing a joint and taking anti-inflammatories immediately right afterwards, you actually are going to make the injury last much longer and probably not heal as well. So our old paradigm of, ice it, start pounding anti-inflammatories really is not the right method, because that first probably 48 to 72 hours, that inflammatory process is trying to help you, right? It's sending in all these macrophages, it's trying to get things cleaned up. If I quell that, there's going to be issues. The big problem lies now is that process should last for a few days. And then we start swapping over and we start switching out our pro-inflammatory cytokines. For those guys who don't know, cytokines are like just little proteins that act as signaling molecules. So we start swapping out these pro-inflammatory cytokines to anti-inflammatory cytokines. So you get this high level of inflammation that brings in all these macrophages that start healing the injury. And then the body slows that process down so that we can rebuild. If I don't turn that off, I stay in this pro-inflammatory state. So now instead of this pro-inflammatory going down and the anti-inflammatory going up, I'm staying here. What happens? I just keep destroying the joint. And so people from a genetic perspective, a hormonal perspective, a nutrient perspective, right? They may stay in that inflammatory state, but there's a lot of just things that are out of your control. You could be the perfect human, have perfect hormones, have perfect nutrient. And there's a lot of things that are out of your control to why that joint would stay in an inflammatory state, some of which is genetics, and some of it is other bad things that are going on in your body. There's more viral influences. COVID has been a big, huge player here. Now everybody's immune systems are taxed by COVID or COVID vaccines, or Epstein-Barr virus. There's all these chronic threats to our immune system. And so basically our immune systems are already struggling in some of us. So then we get an injury. We go into this pro-inflammatory state. My body's already in an attack mode. And so it just stays there. What happens? That starts destroying cartilage even more. And you start that rapid progression. Now, once my cartilage is destroyed more, you actually start getting these little fragments of cartilage that break out that create even more of an immune response. And that secondary immune response causes more degradation. And you've got a vicious cycle until your joints completely bone on bone and worn out. And this occurs in every single joint in your body, hips, knees, shoulders, it doesn't matter. So what should we do? Well, number one, we need to be a little bit different in how we're treating these acute injuries, right? We need to sort of tell people, that first, there are times the only way you're going to get somebody to get off their bed is to give them a little anti-inflammatory, but be careful. And there are anti-inflammatories, for instance, like meloxicam. Meloxicam is a safer anti-inflammatory than Motrin because the pathways it works on are not so disruptive to us. So we'll try and use anti-inflammatories when we have to. If we don't have to, we try and get people through with getting a little bit of motion going, modifying their activity. Never stop moving. Motion is good. So I can tell you every knee injury I've had, I'm right back in the gym the next day. So basically get people moving, let the inflammation ride for a little bit. And then we've got to stop the inflammation. So how are we going to do that? Well, that's where now we potentially might want to pull in some of the different anti-inflammatories, but that's where things like peptides can come in, right? Because peptides are our natural way of quelling inflammation. So if you hurt yourself, one of the ways your body stops that inflammatory process is to produce some of these healing peptides. And the two that are most commonly used for musculoskeletal injuries are something called BPC, which stands for Body Protective Compound 157, and something called thymosin beta 4. It's known sometimes in the sort of social worlds as TB 500, but its real name is thymosin beta 4. And thymosin beta 4 is a thymic peptide. So when we're babies, we have this giant gland in our chest. It's huge. It takes up our whole chest. You do an x-ray of a baby that's massive gland in their chest. About puberty, that gland starts to shrivel. By the time you're old like me, it's a little teeny nub of fat. It doesn't do anything. So I'm not making thymic peptides anymore. That's why your 12-year-old breaks their arm and they're healed in 2 weeks, and I break my arm and it takes me 6 months to heal, right? So basically, if I replace those things, so BPC gets made by the gut in all of us. But again, we make less as we get older, or we make less if we had to use more for something. So basically, I have these peptides that are coming into play. Why don't I help it out? I can give you those same peptides you make exogenously, right? Just like I could give you testosterone that's identical to your testosterone. I can give you peptides that are identical to your peptides. So then we can get people going on these peptides, BPC, thymosin beta 4, to try and stabilize the immune response. So now I've given the body exactly how it works. My goal is always be homeostatic. Do what the body wants. This is how your body heals it, right? So we're going to give BPC, thymosin beta 4. We're going to start them moving, do some PT, maybe some near infrared, things like that to start the tissue healing occurring. And if you can catch that early, the hope is that we are going to prevent a lot of the degradation.
Yeah.
But what else? Some people, like me, have just such high levels of these inflammatory cytokines, it's not going to be enough. So in about 2019, a drug came out in Australia called xylitol. And xylitol is what's called pentosan polysulfate. And it was approved, I think, 2020 in Australia for treating, really acting as a cure for osteoarthritis. And they started utilizing it largely in rugby players, but sort of across the population pretty aggressively at around 2020. And they've decreased the need for joint replacements by over 70%. So this drug, pentosan polysulfate, is going to make it to the U.S. It's in phase 4 trials now. But we can get it. We've been using it since about 2019 in our practice. And the reason we can get it is because the oral form of it, pentosan polysulfate orally, is a drug called Elmiron. Elmiron is available now as an oral medication for bladder inflammation. The problem with it orally is you have to use a relatively high dose, and it's not great for joints. So what they found is by using an injectable form of it, they call it xylitol, but it's injectable pentosan polysulfate, that you actually got much better uptake into joints at a much lower concentration. And what pentosan polysulfate does is it addresses every one of those things that we know goes awry in creating joint arthritis. Almost every one of them. It lowers tumor necrosis factor alpha. It lowers interleukin 1 beta. It lowers something called metallomatrix proteases. And these are, I like to think about them almost as little Pac-Men, that when you get like damage to your cartilage or an injury, these metallomatrix proteases come in to try and clean up, right? The problem is in that cleanup, if they keep going, they start, picture like you have a spot on your wall, you can be rubbing that spot, eventually the wall is gone. Well, that's what these guys do too. So this blocks, pentosan polysulfate blocks those metallomatrix proteases. It blocks another thing called an ADAM enzyme. So a lot of these bad enzymes that are degrading the joint, it blocks. It also blocks something basically called neural growth factors. So neural growth factors are these little nerve endings when there's joint injury, these little nerve endings that start growing into the bone, and they create a lot of the pain that's associated with arthritis. So this actually regulates neural growth factor as well. So it's the one drug We have no other drug like this that can treat every aspect. And it's why it's being termed what's called a DMAO, or disease-modifying agent of osteoarthritis, is because it may well be a cure. Now, the key is, we have a lot of people who have severe osteoarthritis. Are we going to be able to reverse that completely? No, but I have a bone-on-bone joint, and my X-ray still may look like bone-on-bone joint, but because I've gotten all my inflammation down, I've regulated the neurogrowth factors, I actually don't have any pain. I can do anything I want with my knees, even though they're bone-on-bone. So nobody can look at your X-ray and say you need surgery because your bone. We see that all the time. I X-ray a knee, it looks like hell. The patient has no pain. Like they came in to be the right knee hurting. You do both knees and you're like, oh, your left knee looks like hell. And they're like, no, doc, it's my right knee that hurts. So the X-rays don't correspond necessarily. It's inflammation that corresponds. So we love pentosan polysulfate. It is a mainstay of treating osteoarthritis. And I can tell you that we've treated people who were headed to joint replacements, and about 70% of them we've been able to keep from having to move forward with a joint replacement. The earlier you can start this in your life, if you have osteoarthritis or if you have an injury. So we'll use this acutely after injuries, like if somebody tears their ACL, because the earlier you can start it, the better off you're going to be in preventing it.
Wow. Yeah, a lot to unpack there. That was a lot of good stuff there that you just packed in. First of all, this is the first time I've ever heard anyone say about if you have an acute injury. Like, so for example, if I twist my ankle playing basketball and my ankle swells up, I always was like, oh, I got to immediately ice it. I got to compress it. Yeah. And it works. Like you see the swelling go down though, when I do that. So it seems like intuitively that makes sense. This is the first time I'm hearing that maybe that's not the best solution. So are you saying let it swell up, or is ankle different than like a
it's
joint?
Obviously get off of it, get it up a little bit, right? But let some of that inflammatory process happen. It's actually trying to help you. I mean, it's the same reason, really. Everybody, as soon as they get a fever, they take Tylenol. They try and quell the fever, right? Fever is there for a reason. And if your fever goes to 104, you're going to die. You better actually do something to quell the fever. But a low-grade fever for a viral illness is a good thing. And if you quell that fever, the virus will last longer. So the same exact thing happens here. And if you look up, for instance, there's some excellent studies on taking anti-inflammatories versus not, and how rapidly an injury heals. And the same thing true as acute icing. Acute icing is not a good thing. Get off of it. That'll get the swelling down. So get off of it, get it up, and let the swelling kind of come down on its own. It'll take about 2 days. It will. And then you can start, if you want to start moving a little bit more, we can start some anti-inflammatories on sort of a, not super, don't take a ton of them, but that first couple of days, that process is, why does it happen? There's very little in our body that just happens. Our body's really trying to help us. Our cells are really damn smart. And if we let body processes do what they're supposed to do, we mess with things. Our bodies are actually darn smart, and we need to play with that. We need to realize why does our body do something? Inflammation is not a bad thing. Chronic inflammation is a bad thing. Acute inflammation is typically a good thing.
Yeah. Great. And then, so then you mentioned a couple of other things that are really interesting. So obviously people have probably heard all the advertisements recently about the red light panels. And you mentioned those. So I've been thinking about getting some myself, but I'm like, are these things for real? Is there really benefits? What do you think about red light panels?
I think red light has huge benefits. We're learning more and more about using light energy, using sound energy to help tissue healing. Right? Our cells respond to energy. We are just bundles of energy. And that's where whole quantum physics, quantum biology starts playing into everything we're doing in functional medicine, right? We're going to start seeing that stuff overlapping a lot more. All that stuff that we used to think, well, that's kind of woo-woo, that we, these energy fields that we can change things, but it's very true. And you can do a lot with red light wavelengths to heal tissue, especially when you do things like combine it with, like for instance, methylene blue. Combined with red light therapy can be very beneficial to like mitochondrial health, for instance, in people. If you use methylene blue combined with full panel red light therapies, you can do a lot for mitochondrial health. I will say for joints, red light therapy probably does not go deep enough. So it's great for like some soft tissue injuries. It's great for skin. It's great for wound healing. So if you have a little strain, love red light therapy. But probably for joints, you need a wavelength that goes deeper. So that's where I actually like near infrared. So near infrared is out of our light scale. You can't see it. So when you buy these panels, you're going to think they're broken because you can't see anything. Because near infrared light is not visible light. So near infrared light will go about 4 inches deep. So it's going to go down to a knee joint or a hip joint. So I actually like Epoch Lasers makes a near infrared light. So you can buy these panels. They're about $500. They're just about this big, but they're great if you have an acute joint injury, because the near infrared is going to actually get that wavelength down to joint level, whereas traditional red light therapy does not have a wavelength that's deep enough to get that. But I do love red light therapy for a lot of healing purposes. And again, especially for mitochondrial health combined with things like methylene blue, it's kind of an amazing adjunct. So I do like this. But, it's funny because I think people think about these, and we really have to remember that our cells are very much ruled by wavelengths. We use in our practice something called a stem wave, and we'll do this after we do regenerative procedures. Stem wave uses actually an acoustic sound wave. And what they found is that stem cells are actually attracted to a certain acoustic sound wave. It's amazing, but you can see, like, if you put these in a little petri dish and you put the cells and you put the sound wave in, you can see cells migrate toward the sound. So our cells are really cool, right? That they actually respond to these wavelengths is fascinating. So what we can do is, after we do, for instance, a stem cell procedure, we can actually then, do the stem wave over the joint and drive more activity to that level. So we'll follow that with the stem wave. And simply by using this acoustic wave, you can actually drive stem cell activity. You can do that even without injecting stem cells into somebody. You can just get their own stem cells to migrate there when you have an injury. So stem wave can be very powerful. So I think these, light waves and sound waves, you're going to see more and more and more as our field develops, right? As the functional medicine field develops, that we're going to realize this. And it's that it is really how quantum physics and biology are now overlapping a lot, which I love. There's a great podcast on quantum biology. That's, when you start looking at this stuff, it's so cool.
That is so cool. I know. I'm so interested in it as well.
It's fascinating.
It really is. It really is. So we talked about, I'm glad you mentioned stem cells, because I was going to ask you as well. So you do stem cells in your clinic as well?
So we use a lot of what we call extracellular vesicles. And one of the problems with your own stem cells, so if you're 18 years old and you have an injury, and so you can get stem cells usually we get them from fat or from bone marrow. And when you take your own stem cells, one of the issues is, and we used to think stem cells did not develop senescence, but we now know from some studies out of China that that's not true, that stem cells do develop senescence. So if you're 18 and you hurt yourself, probably your stem cells are damn good. If you're 60 like me and you hurt yourself, probably a lot of my stem cells actually already are senescent. So if I take bone marrow stem cells, for instance, and now I inject them into my joint, and some of those stem cells are senescent. So remember, some of you guys are familiar with senescent cells, what we call zombie cells. But senescent cells are damaged cells that should be dead. So our body's designed to, when a cell accumulates enough damage, it kills itself. It does autophagy, murders itself, so it commits suicide, all goes well. But senescent cells, for some reason, get stuck in this live state. They don't kill themselves. They just keep replicating. In so doing, they actually start spewing out what we call SAS, senescent-associated secretory phenotype, that actually starts damaging the cells around them. And it's one of the reasons, as you age at a more rapid pace, is because we're accumulating these senescent cells. And so they truly are like zombies, right? They're these damaged cells that are spewing out these proteins that are damaging the cells around them. So what they found in some of these studies out of China is, when they took cells from either sick or damaged mice and they put them into healthy, like cartilage tissue, it actually initially created a positive response, but over a brief period of time, it actually started having a negative response. So there may be some cautionary tales there that we need to be very careful with using our own stem cells in older people, at least, but probably the older is maybe over 30, because we may be, over the long run, not doing as much good as we thought. I did stem cells for a long time. Now we use a lot more extracellular vesicles taken from placental tissue, and you can use what are called exosomes. And exosomes are taken out of stem cells. And exosomes contain all the microRNAs, all the growth factors. So they're really the working part of stem cells. So if you think about stem cells as like ping pong balls, right? And they're filled with sand. The sand is the exosomes, and the exosomes actually are what are creating the influences to the tissue around them. So what we can do is just take the exosomes. I can fit a whole lot more sand than I can ping pong balls into something, right? So now I can conglomerate a whole lot more. I can conglomerate trillions and trillions of exosomes into a joint or much more than I could do stem cells. And because I'm using a placental tissue, I can actually do that without having the senescent cells involved, right? So basically what we'll do with a joint lots of times is we'll create a fibrin matrix by using your own platelet cells. And then we'll use exosomes on top of that to really help with the regenerative process. So we do a lot more of that. There are a lot of people who are doing different things with stem cells, modifying them in certain ways to help with the senescent properties. So we'll get more and more adept at this. But I do think exosomes are probably going to be where you see the future of stem cell activity going.
Yeah, very interesting. Very interesting. So kind of circling back, we talked about peptides. Specifically, we spoke about BPC 157 and TB 5000. You gave the official name of it.
TB4.
Those are very popular in
Right.
in the industry right now. Kind of being the healing, the Wolverine stack they
The
call it,
Wolverine
the
peptides,
healing.
right? Exactly.
Yeah. Now, so I guess first question is I want to ask you, what's your go-to then? Like, let's say someone comes to you, knee, shoulder. I know every situation might be different, but in general, are you leaning more towards those peptides for healing, as well as the other drug that you mentioned before, or you think stem cells? You kind of lean more towards stem cells. Which one do you think is a little more effective from what you've seen?
Usually it's both, right? We very rarely will do stem cell therapies without also utilizing pentosan and BPC and thymosin beta 4 for the very same reason that we talked about with the acute injury, right? I need to have so if your body is not in a great state to heal, right? If I make high levels of interleukin 1 beta, if I stick my own stem cells or even exosomes into there, even if I make new tissue, what's going to happen? I still have my underlying problem. So I destroy that tissue. So very rarely, unless somebody for some reason can't do it, do we not have somebody on pentosan, polysulfate, thymosin beta 4, and BPC after these procedures, right? Very often, we will start with the peptides and pentosan, and with the plan that we'll get some of the inflammatory stuff quelled, and then can do the stem cell procedure. And about half the time, people are feeling so much better, we don't need to do the stem cell procedure. But we'll almost always start there because I have to get your body into a state to be able to heal. That's one of the dumb things when I see all these stem cell centers popping up all over. If you take somebody who's not in a state to heal, I don't care how many freaking stem cells you stick into them, they're not going to get better. It's the same as what, we're all like, oh, we're doing this progressive stuff. It's no different than what I did with surgery, right? To go in there and trim the tissue and think they were going to get better. And the same thing's happening now because we're calling ourselves, functional medicine doctors now, but we're just doing the exact same thing. We're just canned process of sticking stem cells into there and not treating the underlying problem in the first place. So that's where pentosan, thymosin beta 4, getting the hormones in order, getting the nutrients in order, all becomes the key. So that first appointment is always that. If somebody's really acutely in pain and inflamed, we will lots of times do a very cool procedure where we use something called alpha-2 macroglobulin. So one of the other things your joints do, and your body in general does to heal, is it makes a protein called alpha-2 macroglobulin, or A2M. A2M circulates around your body, and it goes to try and stop inflammation. So it's one of the ways the body turns off that inflammatory process that I said. So that first couple of days, you have this inflammation. Now A2M circulates to the injury, and that could be anywhere in your body or illness. And the A2M comes in there. And A2M is really designed, it really does look like Pac-Man. It's designed to go in there, and it actually captures like that interleukin 1 beta and that TNF alpha. It actually captures them, encases them, and excretes them. So one of the problems, however, is if I have an acute injury, is getting enough of that A2M right to that site. It's going to circulate around your body. Some of it should diffuse into the joint. So what we can do is take your blood, and there's a very special filter that filters out A2M. You can filter out any protein you want. You just have to have the right filter for the right size protein, right? So this protein has a very specific molecular weight. So you can use a filter to filter it out. Now I can collect a whole bunch of A2M. I can put back that back into the joint. It remarkably settles down inflammation. So let's say you came to me 2 weeks after your injury. You're still miserable. Your knee still feels like crap. It's very swollen. I'm going to take some of that fluid off. I'm going to put A2M in. That's going to quell that inflammatory process. You're going to feel a whole lot better. Now we can put you on the pentosan, the BPC, the thymosin beta 4, see how you're doing, wait a little while, and then decide what regenerative therapies we may or may not need to do. So A2M is really interesting. A2M's right now being developed actually as a synthetic, which will be very nice because right now the process to get A2M is difficult. It's just a tedious process to filter it out of your blood. It takes a while. You need a lot of blood. There's not a lot of clinics that do it. So a company called Cytonics is coming out with a synthetic version of this. So basically it looks identical to our A2M, but it's something I'll be able to pull off the shelf and inject into a joint, which will be huge for some patients, especially some people don't make a lot of A2M. I have one patient, she has horrible arthritis everywhere. And when we tried to get A2M out of her blood, we got like this much, we got like none. So that's one of her problems. She just doesn't make a lot of A2M. So for somebody like that, it's going to be hugely beneficial. So that's pretty cool. I mean, there's so many cool things, but so keep an eye on that. Cytonics A2M is actually a pretty cool thing.
Yeah, that sounds really cool. So I want to maybe ask you about some other peptides as well that maybe you're using. But first, I want to ask people that are listening, and even myself, right? I'm like, these peptides, oh, well, they're kind of new. Are they safe? Maybe we should give it a few more years and make sure that they're safe. Like, it's kind of the Wild West. Where are you getting it from? There's all these questions. Why are peptides safe? What should put people's mind at ease? And of course, they have to go to the right place, right? That's again my concern with the stem cell clinics. When people are like, oh, stem cells, I can make some money. Let me open a clinic, and they don't even know what they're doing, right? So you gotta. I highly recommend people go to someone like you who's very knowledgeable, really know what they're doing. But why are peptides safer than maybe some other alternative therapies,
or pharmaceuticals? For your listeners who don't know, peptide is basically where a protein is over 50 amino acids. A peptide is a protein chain that's less than 50 amino acids. So it's nothing magical. They're just links of amino acids. They're just less than 50 versus a protein which is more than 50. Your body makes thousands of peptides. You make peptides just like you make hormones. You make peptides, and those peptides have very important signaling messages throughout your body. For instance, insulin. Insulin is a peptide. Basically, so you're like scared of peptides. Well, insulin is a peptide. It's a life-saving peptide. Insulin, you eat glucose. Insulin tells glucose to go into the cells, and insulin, then everything gets regulated, right? So basically, there's other peptides that do the same thing. So when you talk about safety, yes, you could overdose on insulin, obviously, right? So there are some peptides that too much could be a problem. A lot of the endogenous peptides, meaning peptides that we naturally make, are very safe. For instance, BPC. BPC, at least in animal models, has no ceiling. You could dose it, you could drink it. It's an injectable peptide, but you could dose it 100,000 times higher than you need, and would probably do nothing, at least from the animal studies. And there's no reason
I took it as an oral, by the way, one time. What do you think about oral?
So BPC is available oral. So it does work better for joints injected, but orally it's great for gut. It's helpful for glucose control orally. I love oral BPC, especially for any of you guys who have gut stuff. It is huge orally, but it can act as an anti-inflammatory orally too. So if I have patients who just don't want to do injections on themselves, these little sub-Q injections, I will use BPC orally. It is definitely more potent for joint healing as a subcutaneous injection. But if you're not going to do that, some is better than none. So BPC, very safe up to very high levels. It is one of the few peptides that you can take orally. There's not a lot. Most of the peptides are not. Available.
Right. I heard almost all of them are injectables. BPC is one that can be orally, but you make a great point. If you inject it right into the spot, it's going to be more effective there.
Right.
Yeah, for sure.
And you don't have to inject it into the joint, for instance. Like if your shoulder's bad, you can just do subcutaneous tissue near it. It just appears to be localizing near the joint seems to be helpful. So you don't really have to inject it intra-articularly.
Yeah. What about some people have concerns, like, for example, if they start taking testosterone, then maybe their body will shut down its own production of testosterone. Is there any concern like that with peptides?
Doesn't appear to be. There's really no evidence that using these peptides is going to decrease your own production, right? And I'll even comment there on. I take issues when I hear that with testosterone, because obviously, if you're a young male making a whole lot of testosterone, you really don't need testosterone, right? So if the reason we put somebody on testosterone is because their own body is not making enough. And if I adjunctively utilize it at appropriate dosing, I'm not going to shut down their own production, using it appropriately and using it with things that continue their own testicular production going. So, and there's a very cool new testosterone called Kysotrex that's an oral testosterone. It's the first oral testosterone, we've been able to use it, doesn't affect the liver, and it does not affect testicular function at all. So a little bit of a caveat there is that some of the myths you hear about testosterone are not true. Used appropriately, testosterone will not suppress testicular function, especially some of these newer forms like Kysotrex, which is an oral. I love Kysotrex for younger males because it does not affect testicular function. And there's a darn lot of younger males who have low testosterone. I'm talking about in their 20s. And that's so imperative to healing and everything else in life. So peptides does not appear to be short of some. So for instance, if you do a lot of growth hormone secretagogues, so we don't use growth hormone nearly as much as we use secretagogues, right? So we use things that tell your own pituitary to produce and release more growth hormone. You can just give growth hormone. The problem with just giving growth hormone is it does suppress your own growth hormone production. And when you stop it, you will have issues, right? So, but you can do the same thing with if you overdose the growth hormone secretagogues. So there are some of the peptides you do have to be careful with. Thymosin beta 4 is it helps tissue growth, right? Well, if I help tissue growth too much, am I going to overgrow tissue? Possibly. So those are peptides you might want to cycle in. So there is a lot of nuances to peptides, some of which you could take massive doses of thymosin alpha 1. Thymosin alpha 1 is another thymic peptide. So thymosin beta 4, utilized for tissue healing. Thymosin alpha 1, it's an immune modulating peptide. So it supports the immune system. It helps get rid of infections. It helps you make antibody production. All of us have dysfunctional immune systems as we age, mostly because we don't have thymic peptides anymore. So if I give back thymosin alpha 1, thymosin alpha 1 is a drug in Asia. It's called Asia and India, widely used drug called Zadaxin. Here, it's not even available, right? It's ridiculous. It is widely used there and saves a lot of people who are going through chemotherapy and stuff like that to support their immune system. And here, we have to get it compounded. But thymosin alpha 1 is another peptide that your body makes. Probably more is better. So probably you could dose that peptide massively high and it would only do beneficial things to you. So it really kind of depends on the peptide, whether there is sort of a ceiling dose to them or not. You do have to have a knowledge of peptides. It was funny. I had a patient recently go into AI and have AI devise him a peptide regimen and, and show it to me. And I said, well, aside from probably dosing this at a level that might kill you, it did a decent job. So there's just so many nuances to that, that you do want to work, I think, with somebody who specializes in peptides. I honestly do. I know there's so much out there and so many people self-treating with peptides. And I would say, you guys, anybody can use BPC and safely use it. But other peptides, be a little more careful with, right? So when you ask about other peptides we use a lot, if thymosin alpha 1 is top of my list, because if I can modulate the immune system, I can do so much. As you know, this whole immune disruption, inflammaging, right? That's going to be the root cause of almost every disease. So if I had stayed on thymosin alpha 1 my whole life, I probably would do very well to prevent a ton of chronic diseases. So I take thymosin alpha 1 pretty, on and off just because of cost, but pretty continuously because my immune system is super important, right?
Yeah, absolutely.
How about other peptides? Because I'll bring up one that's going to be controversial to your listeners, perhaps. But if you look at the GLP-1 agonists, semaglutide, tirzepatide, retatrutide, which have gotten a ton of press, and I'm sure all of your listeners have heard of them, right? And the bads and the goods. They are amazing for weight loss, but then you hear all these horrible stories, right? You lose all your muscle, you get Ozempic face. People are dying from taking it because they get bowel obstructions. So again, used inappropriately, these are not good. I will, number one, tell you that the GLP-1 agonists like semaglutide and tirzepatide do not cause muscle loss. In fact, when they were first developed, they were developed for diabetics to actually help drive glucose into the muscle. The reason that people lose muscle on these drugs is because they stop eating protein. They just stop eating. You have no appetite. Right. So I have people follow their macronutrients when I put them on these drugs. If they stop eating protein, I pull the drug away. I'm like, you can't have it if you're not going to eat protein. But if I can keep their protein and take up 100, 120 grams at least, then they're going to maintain muscle or more if you're a guy. Number two, the GLP-1 agonists used at microdosing, used at low doses, are one of the most potent peptides that we have for longevity because there are GLP-1 receptors on your immune cells, on your liver, on your kidneys, in your muscle, on your brain. So there's not one organ system that does not benefit from the GLP-1 agonist. Now, sometimes you have to use a much lower dose, right? Like I have a history of dementia in my family. I watched my mom die from dementia. I'm not going to go there. We know that the GLP-1 agonists are in phase 4 trials for preventing cognitive decline. So I take I'm skinny, so I can't take a lot of GLP-1s, but I take a small micro dose a couple of times a week for my neural protection. And
Yeah.
so these are,
I wonder how
I
much
think,
of
one
the
of the best longevity drugs we have.
Yeah. I mean, absolutely, especially for people who obviously are overweight. I do wonder sometimes about the cognitive benefits. Is like, okay, yeah, if someone's extremely overweight, they're inflammatory, so their brain is inflammatory, right? So like it could. So yeah, I mean, whatever the mechanism is.
Yeah, but so they found that it's not in the obese people; it's in normal
Oh
people
wow.
that
Okay.
that
Huh.
that
Interesting.
that we're seeing the cognitive benefits.
Do you have a favorite? I've heard people say Monjaro has less side effects than some of the other ones, or do you have a favorite one for people who are looking at
So
that?
basically, you've got semaglutide, which is the Ozempic, and then you've got Mounjaro, which is tirzepatide. Now you have the newest, the third generation, which is retatrutide. Retatrutide's, I don't know if it's to market yet. I'm not sure what its trade name's going to be. We get it compounded. But retatrutide is what's called a triple agonist. It has 3 different things. So basically, semaglutide has a GLP-1 agonist, and then semaglutide has GLP, GIP, and then retatrutide is the next generation up. Each one of them is better. So I would say tirzepatide is better than semaglutide, and retatrutide is better than either of them. But with each of that better, you're increasing the cost. It is more expensive. So for me, and especially if you get side effects from semaglutide, tirzepatide, and retatrutide, much less side effects. They are both much more effective for weight loss. For just somebody who baseline needs it for preventative health, and they can tolerate a low dose semaglutide, which most people can, it's much more cost effective to use semaglutide. So I use semaglutide for myself because it's just more cost effective. And a low dose, most people don't get side effects from it. You don't get the nausea and things from it. If you're using them for weight loss and you need to go higher dose, tirzepatide, which is Mounjaro, or retatrutide are better.
Makes sense. And it also makes sense maybe in your practice, right? If someone comes in and they have inflammation, they're very overweight, they're dealing with knee pain, right? Like it's probably part of the protocol.
I use them even in my not obese people, because if you look at the data on the GLP-1 agonists in arthritis, they're very preventative to arthritis, even in not overweight people.
Wow.
Right? We always think the weight is what causes arthritis. It's not. So as you said, it's the inflammation that fat causes. When we're fat, we have high levels of inflammatory cytokines. So fat people have higher levels of inflammation. It's actually not weight. I can have somebody who's equally weight. I can have a 400-pound bodybuilder who's massive muscle, and they don't wear out their joints. A 400-pound fat person does. Why is that? It's because fat's inflammatory, muscle is not.
Right.
So it's not the load on the joint, is the inflammation. It's just more proof. The bodybuilders, you guys are carrying around 350 pounds of muscle, and they don't get arthritis. Why is that? Because they've got very low levels of body fat, right?
Right. Dr. Yurth, this has been amazing. I'm sure there are people listening who may be dealing with pain, maybe want to lose weight, maybe want to optimize their hormones, maybe a combination of all that, just want to live longer, work with someone who really knows how to utilize all of these cutting edge treatments for longevity and better health. Where can people find you, learn more from you, follow you?
So if you guys go to boulderlongevity.com, that's our clinic. We also have a training academy called Human Optimization Academy, which I encourage all you guys to join. We do tons of cool stuff. We have these Q&As. The people in that group, and it's physicians and lay people and health coaches who are all part of this. And we have these Q&As every month that blow my mind, because the questions people ask are so astounding and so educational. So we talk about peptides and hormones and everything new, and we talk about new research. So Human Optimization Academy, which is bli.academy. If you go there and join that academy, it's not expensive, but we have training on how to read your own labs, how to understand peptides. As we went through all these peptides, what are these peptides? Which ones, can you safely use? We talk about hormones and optimizing hormones. So it's some good, education based on scientific literature. So we're trying to teach through science and not through, just that you hear something and your influencer told you it was great. So Human Optimization Academy, bli.academy. You can also reach that through boulderlongevity.com. You can follow my Instagram at Dr. Yurth and our Longevity Institute at Boulder Longevity Institute. We're really focused on learning and teaching. So that's one of my big passions. I do a lot of lecturing. I'm gone almost every weekend lecturing, because I think that the only reason, I love that, your podcast, these are the things that it's very hard to change doctors. I will never change my orthopedic partners. They're making buku money replacing joints. I'm not going to change them. So what we have to do is change everybody else, and eventually medicine will follow, right?
Yes. Yes, I absolutely love that. And you do telemedicine as well for people who are
Yeah,
not?
so I'm licensed in almost all 50 states, and we actually have patients in Canada and New Zealand and London. So we have patients all over.
Amazing. Amazing. Well, thank you so much. This was an amazing episode, very informative, and hope we could do it again sometime.
Appreciate you. Thanks.
Thank you. Thanks for listening. If you enjoyed the episode, can you please leave us a rating or review and subscribe? I've realized that while we have actually increased our downloads a lot, we're actually getting a lot of downloads, which I'm really happy about. We actually have very few ratings. And I realized that I've never asked people really to rate much. So I'm asking you now if you could please rate and review and subscribe. And if you enjoyed the episode, please forward it along to anyone that you think will get value out of this. Also, if you haven't checked out our line of products at buypeakperformance.com, you get 20% off your first order. That's www.buypeakperformance.com. We have some incredible products, including our organic high-altitude coffee. If you don't know this, coffee is one of the most heavily sprayed with pesticides out of any crop. So it's really important that you drink organic coffee. We've gone above and beyond to source what we believe is the highest quality and healthiest organic coffee in the world. We're also famous for our organic green superfood powder. You can get 20% off of that as well at buypeakperformance.com. We also have an organic, vegan, and paleo plant protein. See, most of the vegan proteins out there are using brown rice protein, which is really not a good source of protein, and it's also a grain. And if you're paleo, you know that grains tend to cause inflammation in some cases for some people. And so we wanted to make one that was paleo friendly and vegan and organic. We made an amazing amino acid profile, so it's really one of the best plant proteins for muscle building. So you can check out Peak Performance Organic Plant Protein. You can find that on our website. Of course, all our products are on Amazon as well. So thanks again. And again, please, if you enjoyed the episode, please forward it along to someone who you feel can get value out of it. And please leave us a rating, review, and subscribe. Thank you.